Welcome to the Inertia Exchange Podcast, where we explore the dynamic intersection of medical innovation, prevention, and patient-centered care. Today, we are thrilled to welcome Dr. Nitesh Paryani, a third-generation radiation oncologist and the president and medical director of Tampa Oncology and Proton. Born and raised in Jacksonville, Florida, Dr. Paryani graduated valedictorian from the Bowles School. He then earned his A.B. in political theory from Princeton University. He completed pre-med coursework at Harvard and went on to obtain his M.D. with honors in research from the University of Florida. He completed his internship, residency, and served as chief resident in radiation oncology at the Mayo Clinic, Jacksonville, with additional rotations at top cancer centers, including Stanford, MD Anderson, and the UF Proton Therapy Institute. Formerly an instructor at Mayo Clinic, he now holds faculty appointments at both the University of Central Florida and USF. Dr. Paryani has earned recognition on Tampa's magazine's top doctors list every year in practice and is widely featured across media outlets like CNN and the New York Times. With deep roots in radiation oncology and a growing reputation for innovative uses of ultra-low dose radiation for non-cancer conditions, like tendonitis and osteoarthritis, Dr. Paryani is reshaping how we understand the dual role of radiation in healing and in preventing disease. Welcome, Dr. Paryani.
Thank you for having me, Allie. I'm excited to be here.
Yes. So, and you recently just earned another top doctors, I saw.
I was fortunate to get that honor by my peers. So I really appreciate it.
Well deserved.
Thank you. It's always nice when, your peers recognize your hard work. I mean, I love what I do, and it's nice to know that people appreciate my efforts.
Yeah, absolutely. Well, I'm super excited to have you here today. I want to start off by, we've prepared a few questions that I think will be really interesting to our listeners. I'm going to start off by asking you some of these questions, and then we're going to have some of our other physician, nurse practitioners get into it with you too and get the different perspectives.
Great.
So to start, just a little bit about your personal and professional journey. You come from a family legacy in radiation oncology. What inspired you personally to carry that forward?
So it's funny you ask, because it's the last thing in the world I ever wanted to do. Because I came from a family of doctors, I grew up saying there was absolutely no way I was going to be a doctor. I decided I was going to go into politics and went to college with that plan, did an internship in the United States Senate and said, whoa, this is not for me.
Okay.
And so when I did that, my uncle, who was a radiation oncologist, took that opportunity to grab me into the clinic and say, hey, just come check this out. You might like it. And he was right. I turned out loving it. So I kind of switched tacks midway through college, started a pre-med track, and, the rest is history, as they say, and ended up carrying on the family legacy, again, despite every intention not to. So
what was it that you liked about it?
I liked... So, at the time I was contrasting it to a life in politics. Mm-hmm. And what I thought about a life in politics, and I still think today, is, especially, I worked for Bob Graham, United States Senator, great senator, but the whole office was a cult of personality around the senator. Senator could do no wrong, even if he was wrong, right? You weren't there for your intellect. You were there to agree and for who you know. I always wanted to do a job where I would be lauded for what I did and what I knew and what I learned. And I wanted to do something where I was helping people, and I didn't feel like that. I felt like it was difficult to get the tangible benefits of that in politics.
Yeah.
So, when I kind of saw that experience, and then I saw the clinic, and I said, wait a minute, I've got a decent amount of brains that I've been given, so I can use those, and I can also work with people and help them. I mean, it just seemed like the obvious choice.
Feel like you made the right decision?
I mean, there's still times, I reconsider. But no, I think overall I made the right choice. As I joke with people, I was a political theorist in college, so it was either med school or McDonald's at that point. So I think I made the right choice, but, I certainly don't have too many regrets.
That's awesome. Were there any formative experiences at Princeton, Harvard, or Mayo Clinic that really shaped your path?
Yeah, I mean, again, I think that internship with the senator really was, it's funny because a lot of people, when you ask them that kind of question, they point to something that pushed them in the direction where they're at, whereas I'm pointing at something that kind of pushed me away towards where I'm going. And I think there is some value in that, as what I tell, my kids and I tell young people that I mentor is, you can learn a lot by doing something that you don't enjoy because you learn that you don't enjoy it.
That's right.
And I think that's important. And oftentimes we don't give, I think, enough credence to that. We always say, well, you should focus on what you like, but learning what you don't like is equally important, I think. And so
100%.
That was a big experience for me. And then, like I said, I think just doing that, the following summer after that is when I went and, shadowed my uncle and his partners in the clinic. And I think that was a transformative experience for me too, because that's when I said, hey, this is something I want to do.
Yeah, that's where you can really see yourself helping people.
Yeah, exactly.
Yeah, I love that. So I really want to take a deep dive into what radiation is, because I think a lot of our listeners probably have no idea. And even me as a medical professional, there's a lot about radiation that I don't know. So in everyday terms, what exactly does radiation do to cancer cells and to non-cancer cells?
Sure. And I think, it's a great question, because I think for a lot of people, you're right, even medical professionals, radiation is kind of a black box. It's not a standard rotation in med school. Everybody does primary care, pediatrics, everybody does some sort of surgery. A lot of physicians will go their entire career never having seen a radiation oncology clinic. Mm-hmm. It's just not part of their training. I used to laugh, there's always sort of, and this being in the healthcare profession, there's little cartoons for each profession, right? Mm-hmm. And the one for radiation oncology is always an empty chair with a bubble that says who? Because nobody knows what we do. And it's really, I think because of that, there's a lot of fear that doesn't need to be there. I think the word radiation is just scary to people.
For sure.
Right? It sounds like it's something that's unnatural or dangerous. And, in the wrong hands, it can be. But, what I always tell patients is radiation is one of the most natural substances out there. It's surrounding us right now. We get radiated every time we walk outside our house. Every time we go on an airplane, we get more, and it's not necessarily harmful when it's used the right way. So what does radiation do? So radiation is very good at killing cells that are rapidly dividing. They are more sensitive. The reason cells start to rapidly divide in the first place is they're not able to repair the damage to their DNA. So we take advantage of that, and we damage the DNA further, which allows the cells to die off. Mm-hmm. And obviously, cancer cells are a prime example of that, because they're rapidly dividing, and we can kill them off because of that rapid division. But what we've learned is also inflammatory cells are the same way, which is where the idea of this low-dose radiation for inflammatory condition comes in. And, we'll talk more as we get through the podcast just about the history of it, but it's just, we're in a really exciting time in radiation therapy now, where we have the technology to deliver low doses of radiation safely and really help combat a lot of these inflammatory conditions that are becoming so prevalent in our society in a way that doesn't bring a lot of side effects and can bring a lot of benefit.
That's so interesting. So inflammatory cells are similar to cancer cells in the sense that they replicate quickly.
Correct. And so we take advantage of that similarity to attack them.
That's very, very interesting and new information for me.
There we go. Good.
So radiation, when used in the right dosing and strategically, can really tell the body, hey, work on this, fix this, be better.
Exactly. Because, and I think you and I were talking a little bit before we started the podcast here, a lot of what comes down to these conditions is we've been treating them the wrong way.
Right.
We've been trying to treat the effect, not the cause, right? And the root cause of treating the inflammation is really where the radiation comes in, because by bringing down the inflammation, we let the body start healing itself as well.
Very, very interesting. How is it different mechanistically? That is a word I haven't read on paper in a long time. How is it different from chemotherapy or surgery?
Sure. So, in cancer, we kind of have the big three-pronged approach, right? There's surgery, chemo, and radiation. Surgery, I think everybody knows what that is, right? We take a knife and we cut something out.
Right.
Radiation, again, we just talked about, is really just high-energy X-rays. That's all it is, that we isolate to a certain part of the body. And radiation is a lot like surgery because it's isolated to a part of the body, meaning the side effects then are limited to wherever we're treating, right? If I'm radiating a breast cancer, you're not going to lose your hair because I'm radiating your breast, right? Chemotherapy is a medication, and it is delivered throughout the whole body. And I think that is traditionally what people think of when they think of cancer treatment. They think of chemotherapy with the hair loss, the nausea. And, obviously chemo has gotten a lot better than it used to be, but still it's a systemic therapy. It goes to the whole body and has systemic effects. But for many cancers, we need all three to be successful. And it really just kind of depends on the type of the cancer, the stage of the cancer, and, the patient's condition in terms of what we can use.
That's really interesting. And like you said, patients do often fear radiation. Is there anything else that you could say to help dispel that fear? I mean, even in the cases of cancer, do you feel that that radiation is something that people should fear?
Well, so, it's always funny to me, especially like, for example, I treat a lot of breast cancer. And what I always find fascinating is at the end of the treatment, 9 out of 10 breast cancer patients will tell me the radiation was the part that they were scared of the most, but ended up being the easiest.
Right.
Right. And I think it's that fear of the unknown can really get to us just as human beings in general. Right. Obviously, radiation it's a spectrum, right? If I'm radiating a breast, it's relatively easy to get through. When I'm radiating patients with head and neck cancers and we're radiating the throat, that's one of the most difficult things a human being can go through.
Yeah.
And so I think a lot of it is understanding where we're targeting, what the side effects involve. And I mean, certainly I don't think, it should be something that there should be a healthy amount of, I think, I don't know if fear is the right word, but a healthy amount of maybe trepidation when you're approaching the use of radiation, because it is, it can be dangerous if in the wrong hands and used incorrectly. But, obviously it plays an important role to help return people to function and to battle, these aggressive cancers. And, what's exciting is when my grandfather was a radiation oncologist, in the 1950s and 60s and 70s, he cured less than half the people that walked through his door. I can confidently say I cure 70 to 80% of people that walk through my door.
That's
which
amazing.
is, I mean, talk about in a generation, that's the improvement we've made. And a lot of that has been from the improvement with radiation. We've gotten better at delivering it. We've gotten better at targeting. We've gotten better at sparing normal tissues.
Yeah.
It just keeps getting better and better.
It does. And just because it reminded me, I also recall that you, and something that I probably should have said in your intro, is that you have always taken care of patients that even can't, that have less access, right? I know you've always done that, and your dad and your grandfather, right? And I think that's something really special.
Yeah, one of the founding principles of my grandfather's practice is that we don't turn away a patient no matter their ability to pay. Because these are, it's different. This is not, I think, routine care. This is cancer care, right? These people have no options often. And I've always made it a policy. And in fact, we affiliate with some hospital systems. And the only thing that are in our agreements with the hospital systems is that they cannot have us turn away a patient because they can't afford to pay, because that is our group's priority. And, it's something that I hope to continue for the rest of my career, because, I'm very fortunate. I think we're all very fortunate in what we do, that, we're well off and we can live a good life. But there's a lot of people that, are not in that boat. And I would hate to have them. And I see it all the time. I see people turn away cancer patients, and it just breaks my heart.
Yeah.
It's just something we're not going to do.
I love that about you. You're extremely smart. You're so passionate about what you do, and you have the biggest heart of anyone I know. So you're really an exceptional person.
I appreciate that.
I would love to take a moment to switch the seat and bring Dr. Spiewak in.
Great.
I think it'll be really nice to have doctor to doctor questions and interactions. She will obviously be able to ask even different and better questions than I can. So Dr. Spiewak.
All right.
Thank you. Talk to me about the development of the ultra low dose radiation protocols that you've developed.
So this, to me, is kind of a passion project.
Mm-hmm.
Low-dose radiation, believe it or not, we've been using low-dose radiation for inflammatory conditions like arthritis, tendonitis, and bursitis, amongst others, and plantar fasciitis, for about 110 years. Mm-hmm. And we used to do it a lot in this country until about the late 1970s, and we stopped for two reasons. Around that time, we had the 3 Mile Island nuclear disaster, where the power plant had a meltdown and public perception of radiation turned really sour. Mm-hmm. Around the same time, we developed opioid pain medicines. Mm-hmm. And we said, this is going to be our panacea. This will solve all our problems. Well, fast forward 40 years, what happened? We created a bunch of addicts, and we didn't cure anything. And so around that time, there started to become a renewed interest in low-dose radiation in the U.S., one, again, because the opioids weren't working. Two, because during that span of 40 years, we'd gotten a lot faster at treating cancer patients with radiation. It used to take several weeks to deliver the average course of radiation. Now the average course gets done in about 2 to 3 weeks. So that opened up more time on the linear accelerators. At the same time, the accelerators got more targeted. We were able to treat smaller volumes more accurately. So all of that created kind of the perfect storm for low-dose radiation to sort of make its resurgence in the U.S. But there weren't a whole lot of providers doing it. Well, around the same time, I developed Achilles tendonitis in my left heel. And I went through every treatment under the sun: lasers, red light lasers, green light lasers, physical therapy, you name it, oral steroids. Nothing worked. And I got desperate. And so I read about these studies out of Germany using low-dose radiation, and I asked my partner to perform it on me, and it changed my life. I mean, I spent a whole year limping around my clinic, and then I got this procedure done, and a couple months later, I was back to normal, back to the gym, strengthening, and I said, wow, if this really works this well, this is something I need to start offering to patients. So, we were the first practice to start offering this in the state of Florida. We've now treated over 100 patients, and we've had just amazing results. And what's great about it is I've never, this podcast is probably one of the first times that I've never really actually marketed the procedure. It's just something that patients have told other patients because they've had such great responses.
Yeah. What's your favorite patient success story?
Oh, I have a couple. So I've got one lady who was in her 80s, and she used to be a concert pianist and had to stop playing for 10 years due to arthritis in her hand. She's not playing again.
How did you treat her hands?
So every treatment we do, we basically immobilize the area and we just fire x-rays at it.
Yeah.
So it's pretty easy to do. Usually it's a table. So you're lying on the table either on your belly with the hands in front of you or on your back with your hands over your head.
Okay.
So we did that. And then another one I really enjoyed was another lady, again in her 80s, who came into our clinic in a wheelchair and 3 months later was walking again because we treated her knees and got her back up and moving.
So for just like regular age-related osteoarthritis even you get really good results. How do you pair it at all with lifestyle interventions?
So we do. And so what I tell folks is, the radiation, so the way it works is you get 6 treatments delivered over the course of 2 to 3 weeks. But the pain relief's not immediate. It takes 2 to 3 months after we're done for that inflammation to calm itself down. So after that 2 to 3 months, presuming the patients have gotten a good response, and the literature suggests and our results correlate that about 70% of patients get a response. And so for those who get a response at 3 months, that's when we start to do the lifestyle modification. Get back to the gym, strengthen the surrounding muscles, get into physical therapy. Usually these folks have done all that prior to the treatment with limited success because they weren't able to break through the pain of the inflammation. So that's and I'm always kind of cautious with folks. Don't jump in too early to the physical therapy because you may set yourself back.
Do they is it just a gradual improvement of their pain, or do they kind of wake up one day and they're like, wow, I feel a lot better?
And so it's variable. So I tell everybody it could be 2 to 3 months. Some people respond sooner. I have some patients that start to get relief even before we finish the course of therapy. But on average, it's about 2 months, and it tends to be a very gradual process.
Are you doing sports-related injuries too?
We are, yep. So we do a lot of tendonitis, a lot of tendons, a lot of patellas, rotator cuffs.
Okay, shoulder,
Yep, we do quite a few of those. And interestingly, what I've found is that the tendons tend to actually even respond better than the bones. Usually because most patients with arthritis have had it for a decade plus. Whereas tendons, we usually don't let go that long.
You haven't had enough time to acquire a lot of problems.
Exactly.
Yeah. Okay. That's super interesting. I can think off the bat, like a few people who need to head away to try that.
I mean, what's amazing is every time I treat something new, tennis elbow, golfer's elbow, and one patient gets a response, then I'll get like 10 of those over the course of the next week.
Yeah, because that's
all their friends. Exactly.
Are you doing any younger people, like athletes, high school, college?
Not that young. So probably the youngest I've done, I was roped into treating somebody in their 30s because it was somebody that had, again, kind of appealed to my own story, had gone through everything and had no other options. The guidelines suggest we should do it at the age of 40 and above. Now, the reason for that is the hypothetical risk of radiation causing a cancer. That's always a concern whenever we're exposed to any source of radiation, even as simple x-rays or CTs, there's the risk of radiation causing a cancer. What's great, though, is we have the data out of the UK and Germany for 110 years. They've been doing this procedure, again, throughout that entire time. In Germany, they treat 1 million joints a year with this technique. And knock on wood, we've never seen a single cancer.
Okay.
And the reason for that is twofold. One, the dose is so low. But number two, if you think about where we're treating knees, elbows, feet, hands.
What cancer are you going to get?
There's no organs nearby.
Yeah.
Exactly.
Yeah.
The worst thing that may happen is a skin cancer, which is very easy to solve. Even that hasn't been reported.
Yeah. So where do you think that part of your field is going to go in the next 10 years?
I think it's going to explode. So if you look at our national society, the American Society for Radiation Oncology, this has been front and center for the past 2 years in our annual meetings. I think we're just going to see larger and larger uptake. Again, there are very few insurance-covered techniques that are successful with these conditions.
Is this insurance covered?
100%.
100%?
It's amazing.
Even for OA?
I've never had a rejection.
Really?
Yep. And what's the reason for that, right? Number one
Medicare
is...
too?
Medicare too. Yeah. And even Medicare Advantage plans pay for it.
Wow.
And they pay for almost nothing.
No. Yeah.
and the reason insurance companies do it is, we've got 110 years of data, but number two, it's significantly cheaper than a joint replacement. And for a lot of patients, we've been able to help them kick the can down the road and delay joint replacements.
That's awesome. I'm going to have to start referring some people over to try that out. It's covered even for plantar tendonitis, everything?
Tendons, splash, and bursitis, all of it covered, yeah.
That's great.
Yeah.
Okay. So shifting gears a little bit, wanted to chat about early detection of cancers.
Yes.
What do you think the future is for that?
Well, I think near-term and long-term future, right? I think long-term future is, right now we're doing testing for cancer recurrence patients on what we call MRD, minimal residual disease, blood tests, right? And I think that's where the future's headed. I think there's going to be screening blood tests for a lot of cancers. Right now we only have them for a few types of cancers, most notably prostate cancer. But I think there's going to be more and more blood testing. But in the meantime, we still got a lot of great tests that we can do with imaging. We've got mammography, which is game-changing. Pap smears, I understand you guys do that here, which is fantastic because it's astonishing how many women go without those kind of tests for many years.
Yeah, for sure.
And then, one of the more exciting ones recently is the low-dose CT screening for lung cancer, which, I'm glad to see you're nodding your head. A lot of our older colleagues maybe not as familiar with that.
I have noticed it. For no apparent reason, it's slow on the uptake.
Yeah.
I don't really know why.
Which doesn't make a lot of sense, right?
It should have been like an automatic A plus B equals C.
Yeah, I would agree with you, yeah.
It's just a very linear thing to do. I don't know why it's...
And from an oncologist perspective, you send me somebody with stage 3 lung cancer, which is usually when it presents, right, when they get symptoms, I've got a 25% chance of curing them. You send me somebody with a stage 1, we can do 5 days of radiation at a 90% cure rate.
Yeah.
So, those kind of screening tests are no-brainers. I agree with you.
No, I love them. I used to do calcium scans as a way to do cheap backdoor lung cancer screening.
That's genius. Yeah, because they're looking anyway. Yeah.
And they comment on the lungs. So if I had anybody who was worried or was a smoker, I'm like, let's just do a calcium scan. It's 2 for 1. It's $100. You just send them over there and I get the results really quickly. So now, I still do that if I don't think insurance will cover it. Yeah. But yeah, absolutely. Everybody should.
And so, for us, one of the big things we do is if you become our patient, you become a patient for life. We keep monitoring you for cancer recurrence. But one of the other things we really push is to make sure you're getting screened for all your other cancers. Because I appreciate the fact that as primary care providers, there's millions of things you guys got to do and things fall through the cracks, right? For us, we just focus on the cancer, making sure that it doesn't come back and you don't develop a new one.
That's awesome that you're thinking big picture like that.
Yep, exactly. And then, the other thing I would like to mention, for the men out there, prostate cancer screening is not what it used to be. The blood test can pretty much take care of business. So don't be scared about going to the doctor. A lot of men were scared of the rectal exam. Yeah, it's just a blood test.
There's no finger in there.
Exactly.
I kind of joke about how quick we made a blood test for the men's rectal exam, but women are still getting pap smears every year and there's no blood HPV tests.
So I've got a great slide I used to give on talks that had on women's cancer when I give breast cancer talks, and it was the manogram as opposed to the mammogram, 2 paddles, and you can guess what goes between.
Yeah.
Clearly we never invented that technology.
They don't care about testicular cancer that much. They don't
exactly.
Get it. Okay. What I know you're starting to branch into more teaching now in your practice, and you're going to be bringing in residents. So what kind of excites you doing more teaching for the future of radiation oncology?
So yeah, we've had medical students rotating through for the last couple of years, and I even I work with my alma mater, Princeton. We get an undergrad every year too, which is exciting. And now we're going to start residents, as you mentioned. And I'm excited because number one, it keeps me on my toes. I'm at that point in my career now, 10 years after training, where I've got to be very careful about letting those skills kind of coast and making sure I'm still picking up new.
Comfortable.
Exactly, can't get too comfortable.
Because they will call you out.
Exactly, which I appreciate. And for me too, like I said, we're treating a lot of these patients, and I would love to get some of our data out there, and I don't have time to do it. We have what I think is probably one of the largest data sets for low dose radiation in the country, and I'm going to have one of our residents work on publishing that, which I think will be really helpful.
That's great.
And I think, I think the patients benefit too from the more people that see you, the better off you are, right? The less chance of errors, less chance of mistakes. The other thing I personally like about teaching is I'm a little bit of a dinosaur in the way my practice is structured, in that I'm an independent provider. Most providers now work for large health systems, especially in radiation therapy. It's almost an 80-20 split. And I like that some of these younger physicians are getting to see that it is possible to exist on your own, that it is possible to run your own practice and have a good quality of life and take good care of patients. Maybe it'll start a resurgence. I can only hope.
Don't have to be a part of the machine.
Exactly. And you can avoid burnout very easily that way.
Yes. Yeah, it's critical.
So even a more advanced prostate cancer can be treated with radiation by itself. We know that that's an equivalent scenario. Another example is, like I was talking about the early stage lung cancer, stage 1. We can do what's called radiosurgery, where we treat over 5 days. The patient never even had a needle in them.
Okay.
Yeah.
Oh, yeah. You take care of somebody that I know, and I'm very
Yeah. I mean, a lot of brain tumors are treated with radiation alone. Head and neck cancers are exclusively treated with radiation. We actually don't operate on those anymore because we know that it leaves people with loss of function. Skin cancers can be treated with only radiation. We can do that in 6 sessions.
Do you think that's being utilized frequently?
So it's interesting. So skin cancer is probably one of the most interesting. There's a study that came out that, most skin cancer is not treated in a multidisciplinary fashion, right? It's a dermatologist treating it,
Yeah.
right? Yeah. And they just cut. At institutions, and there's only a handful of them in the country, where they have a multidisciplinary tumor board for skin cancer, 20% of patients get radiated.
Oh, interesting.
At institutions where they don't, 4%. So it's definitely underutilized. So I'll treat a lot of skin cancers on patients that are former patients of other sites because they didn't even know skin cancer was an option until until they got their prostate treated with me. In fact, I'm treating a guy right now. He's got one on the back of his scalp, and he's like, "I don't want them cutting on me." And I said, "You don't have to."
Is it a squamous?
Yeah, it's a squam.
Yeah.
So what do you think is the etiology why it's being underutilized? If the technology is there, the knowledge is there, and the evidence is there?
It's. I mean, and you're
siloed into derm.
Correct. It's referral patterns, right? Patients don't know that they have the option.
Skin cancer,
right?
Dermatology.
Yep,
So
exactly.
In some cases, you're using radiation alone, not even excising it.
Correct. And cosmetically, so if you read the textbooks, would argue that skin cancer on the face should be treated with radiation.
100%.
Because we're not creating any scars, right?
Right. Those procedures are still invasive.
Exactly. The one place the surgeons will actually refer, though, is the anterior tibia. Because there's terrible blood supply here.
Oh, they don't want to. They don't want to operate there. They're going to get
And that one, I mean, I think that makes sense to me. But I think I'm giving them even less benefit than the people in the face, right? Because the people in the face, you're being able to avoid the cosmetic injury.
But they went to a Mohs fellow.
Exactly. They get charged for each layer. They charge. Now, what's interesting though, here's the crazy part: is there's a couple of dermatology practices in town that have bought a low energy radiation machine and use it in office.
It's interesting.
Which is terrifying to me.
Because they know what they're doing.
Exactly. And, for example, in my clinic, you've got me, the radiation oncologist. Then you have the PhD level physicist whose job it is to QA that machine every day. Those machines don't have physicists QAing their machines. So you don't know if it's delivering the dose correctly. You don't know, and I've seen some
tissue injuries.
Correct. I've seen some pretty gnarly injuries from some of those machines that make me uncomfortable. But in Florida, it's unregulated. So we can just, you can just.
Florida's the Wild.
Yeah, it is the Wild West. Exactly.
It's not as bad as Texas, and Miami seems to be its own state.
Yeah, that's true. I read a statistic. Miami, there's more Medicare fraud in Miami than the rest of the United States combined.
No shock.
Yeah, right. Yeah. No surprise.
If you've driven through Miami, everybody gets that.
Everybody gets a wheelchair, I think, if you. Yeah.
You want a BBL? Yeah. You got it.
Everybody has 3 wheelchairs, even if they don't need them. They get them ordered. So, yeah.
So that's so interesting. I mean, that's fascinating, especially for us. We see a lot of skin cancer.
Yeah. That stuff. So if you have folks that don't want to get, cut on, it's 6 treatments, actually similar to the low dose radiation. It's relatively easy to do. We do see, there's some long-term effects in terms of telangiectasias or skin changes, but that's all stuff you guys can fix.
Yeah, you can zap
You know what I mean? And that,
Yeah, and I think in some cases, telangiectasias and redness,
it's easier than a scar.
It is.
Yeah.
Oh, sure.
Exactly.
Yeah.
Exactly.
But so when you're doing it, you're when you do radiation, would you check for clear margins? Are you?
So what we do before we treat any patient, we scan them in our department with a CT scanner so we can see how big the tumor is. And then what we do is we treat with a margin around it to ensure that. And so, we have pathologic studies because there have been so many surgeries. We know the average distance each cancer will travel outside of its radiographic edge. So we cover with a margin around it. And so that's why if you look at all the studies, especially in skin cancer, it's, 98, 99% cure rate, whether we do radiation or surgery.
It's no different.
The same difference. Yeah, it's no different. Exactly.
Is it crazy that I think that it's
it's reasonable for a radiation oncologist to be involved in every derm practice, or should that not be a collaboration?
If our financial system in medicine were different, I think that would absolutely be what would happen.
Because it's reasonable.
Correct. So if you look in Australia, which is a lot like Florida, tons of skin cancer, they have one of the primary modalities in the treatment of skin cancer is radiation. Because again, their economic system is different than ours, right? There's the incentive for the surgery is not there. But yeah, they use a ton of it. Like the Peter MacCallum Cancer Institute in, I think it's in Melbourne, it treats more skin cancer than anywhere in the world because it's just part of their routine.
That's interesting.
Okay, so let me ask you some of my stupid questions again. So let's say you have a condition that's let's say fatty liver.
Okay.
Right? Like this is a metabolic disorder, but on the principle of obviously outside of doing things that help with metabolic disease, is there any place for radiation and things like with fatty liver and
nothing that we've explored. No, nothing we've explored there, unfortunately. It is interesting. There are all these new avenues that radiation is being utilized. So, maybe in the future, I'll tell you some of the cooler ones that maybe not related to what you asked, but just I think what are cool is there's big programs now in what's called functional radiosurgery. So patients with Parkinson's tremors, we're radiating. You've seen that? Yeah, we're radiating the brain to basically kill the tremor. I'm one of the only folks in the Tampa region that does this because I'm crazy. But I do radiosurgery for trigeminal neuralgia.
Oh.
Yeah. So, it's basically what we do is we sever the trigeminal nerve right at the brainstem with radiation. It's the highest dose of radiation you can get for any procedure.
Interesting.
It's delivered in a single treatment. And it's about 50-50 in its efficacy, but part of the reason I do is I started this when I was at my training in Mayo. For whatever reason, I just happened to be on rotation when several of those cases came through. So I did several of them. And they're the most grateful patients you will ever treat.
Oh, yeah.
They're so...
Because, we all know when, we went to school, we were taught trigeminal neuralgia, that's the suicide disease, right?
Yeah.
That's patients who kill themselves because the pain's so severe.
Yeah.
And I'll never forget, I treated this one lady and she wrote a letter to the CEO of Mayo Clinic being like, I cannot thank these people enough for what they've done for us.
Yeah.
And it's one of the letters, we all have our little folder that we keep.
Yeah.
It's one of the ones I keep to remind me because it's probably about the most high-risk procedure a radiation oncologist can do.
Yeah, you're hitting the brainstem.
Right near the brainstem,
Yeah, don't sneeze.
Exactly. That's exactly what it is. That's exactly what it is.
Don't breathe.
Yeah, don't breathe. Exactly. Yeah. But those are the kind of things that we're exploring. Another area we're exploring actually is Alzheimer's. We believe that the amyloid plaque that builds up in Alzheimer's may be susceptible to radiation. So they're doing studies right now on that.
Do they just do low doses, whole brain?
Yeah, exactly. And the way they found it out is by some patients who ended up getting an abnormally number high of CT scans and started to have improvement in their Alzheimer's symptoms. Isn't that wild? Yeah.
Oh my gosh. See, that's fascinating. That is kind of where I was.
Yeah, it's just finding things by accident, right?
Everything, almost everything
is found. Almost everything in medicine is found by accident. Exactly. And then we do, we do thyroid eye disease. We treat that with radiation. When men develop gynecomastia, especially if they're on hormone therapy for prostate cancer.
You can get rid of gynecomastia with low dose radiation therapy?
Yeah.
Oh, that's
we do it all the time.
Because the only way you can do it traditionally is surgery.
Yeah, we have ways to do it with radiation.
That's awesome.
Yep, it is relatively easy. I can't recall these. I think it's like 4 or 5 treatments.
Just kill it.
Removing the breast buds. Exactly.
Yeah.
Just target the breast
and then
buds.
the body just flushes it out.
Yeah.
It's very effective.
Hey, so
Very effective, yeah.
What's the treatment like with cellulite?
So it doesn't seem to work on fat.
Damn.
Because fat is radio resistant. I have a partner of mine. A partner of mine wants to do radiation for obesity, and her plan. It's hilarious. I mean, she says this tongue in cheek, but it's hilarious. She goes, "Let me just give 8 gray to the back of the base of tongue. We'll burn their tongue so bad they won't eat for 3 months. They'll lose a ton of weight.
It'll work.
I mean, it's an extreme solution, but it'll work. You'll be on pureed foods for a couple of months, and then you'll lose a ton of weight."
I wonder, there's no big organ applications, though.
It's been fascinating to me working with lasers that every treatment that you do has a target.
Yep.
And
your side effects are limited to where you're targeting.
Give it just enough energy to tell your body to turn the healing cascade on. And then our bodies are such amazing healers that they go into repair mode. And I guess sometimes our bodies are just straight up sleeping.
Yeah.
And the radiation or the laser or the red light, whatever it is for different conditions.
And part of it too is, we talked about this a little bit before the podcast, right? Is a lot of what we've been doing historically in medicine is doing the opposite, going the wrong way. We have somebody with arthritis or tendonitis, we give them a steroid, thinking we're going to, calm things down that way. But what we've done is delay the healing.
Right.
We've stopped the healing. You can't heal if you get steroids, right? We're turning off.
You can't get surgery.
Yeah. You can't, exactly. So all these things, so we're learning that we've got to jumpstart the body's natural processes, and that's where this low-dose radiation is so fascinating. It's just killing those inflammatory macrophages, letting things calm down so the body can actually start to heal itself.
Do you feel like because you're initiating the body's own healing cascade, like your younger patients have a much better response?
I haven't looked at that, and I'm not even sure that we stratified by age, but what we have stratified by is the aggressiveness of the disease. We know that the earlier we intervene in an inflammatory process, the better off it is. That's what we're talking about, tendons versus arthritis. A lot of these arthritis patients, they've had it for decades plus, and I think it's a lot harder to break that cycle once it's been sort of ingrained, which is not to say that we don't see responses, but I think where I see the better responses is earlier stage of the disease.
What if you had something like a complete tear of, let's say, like a meniscus? Do you think that
That's where it gets complicated. And when it comes to knees and spines is where I have the most, I think, nuanced conversations with patients, because these are both areas where pain is often multifactorial. It's not just arthritis. It's, like you said, a meniscal tear, or in the back, it's a bulging disc or a slip disc. The hard part is we don't have any tests to say what's driving the pain. Is it the meniscus or is it the arthritis, right? There's no test we can do. And a lot of times people can have torn meniscus and don't even notice it hurts, right? So what I tell folks is, in that scenario, I think it's reasonable to try the low-dose radiation, assuming that the arthritis is the driver of the pain, because again, the treatment has no side effects. So if it doesn't work, all you've done is waste 6 days of treatment, 15 minutes a pop, not a huge investment, right? And then you can go on to address the structural issues afterwards if this treatment doesn't work. And I mean, it's been a relatively successful approach, because for a lot of folks, the pain just goes away, and that meniscus that their orthopedic surgeon didn't want to touch, they still don't touch because it's not causing a problem.
Yeah. Cool. Do you always see skin changes when you're doing it?
Not at the low dose. Not at the low dose. No. So at the low dose, we don't see any skin effects, which is nice.
Let me just throw off more of my crazy questions. What about something like a toenail fungus, right? Because those are really difficult to treat.
Like onychomycosis.
Can you low dose radiate?
I've never tried that. Well, you're our test patient. There you go. Well, no, it's fun. It's funny. I thought what you were going to ask, though, was what about the effects on the toenail? Because what can happen, though, is when I radiated my foot, I actually got a band of hyperpigmentation on my toenail.
Oh, that's interesting.
I'll fix that.
It's slowly growing out. It's going to solve itself. Yeah. It's like the rings on a tree. It reminds me how long it's been since I've had my treatment. Yeah. But no, I don't. I mean, the problem with infectious stuff is, while radiation can calm the inflammation secondary to the infection, we're not treating the underlying infection. Right. It's not, these fungi and bacteria are not that susceptible.
I can kill fungus with certain lasers that I have, like a 1064 laser that's not ablative, and it builds up enough heat to actually destroy the fungus.
Yeah, see, for us, that's not really the case, because we're not relying on heat as our mechanism of cell kill. Our cellular killing comes 2 ways. One is, when the radiation passes through, there's double-stranded breaks in the DNA of these rapidly dividing cells, so they die off instantly. That's about 1/3 of the cell killing. And the other 2/3 is actually a free radical cascade. So radiation causes free radicals to build up in these cells, and they die off over time, which is why when we're treating folks for cancer, especially, we tell them to hold any antioxidants, like high doses of vitamin C and things like that, because we want the oxidation. Exactly.
Yeah, no walnuts.
Yeah, don't overdose on. And I mean, obviously, you can do your normal intake, but then you got the folks that are taking 1,000 milligrams of vitamin C a day. You got to hold off on that.
Interesting.
You want to?
That's so. I want that effect.
Really,
I tell patients that all the time because they forget. Sometimes they come in for like radiation therapy.
Yeah.
And then they're going to IV lounge and getting
vitamin C.
Yeah.
Don't do that. You're working against yourself.
Know each other because you used to do oncology. It was at Moffitt, but you were
took me at Moffitt.
But you probably got a TGH.
Probably.
Yeah, we might have also just seen each other's notes all the time.
Name.
She would read all of the notes. It's so detailed.
I love it.
Well, this is super interesting.
Yeah.
Thanks for having me. I really enjoyed this. This is a lot of fun.
Question.
Yeah.
Almost.
No, so they don't work on lipomas, unfortunately, because it's just fat. Yeah. Just the fat. Yeah.
I'm thinking, like, what about a really old cirrhotic liver? Like, what if you just zap it a little?
I mean, we've never tried it.
If you can low dose radiate something that's cirrhotic or fatty or whatever, I guess it doesn't work on fat, so that won't work. But can you get those cells to start
jump starting? I don't think we've tried it. Yeah. I mean, what was interesting is during COVID, there was a lot of studies on the use of low dose radiation for COVID.
Yeah.
We were doing lung radiation on people, to bring down the the ARDS symptoms, and it was relatively successful. It's just by the time we published our data, most of the wave passed, so it wasn't really needed.
That's interesting. That's super interesting. I'm gonna think about it and ruminate on it a little bit.
I love what you're doing. I think we can absolutely, and we will be sending you patients.
Yeah, we'd love to help.
Fungus and shoulder.
Yeah, there you go.
It's the whole spectrum.
I mean, I got to say, I love treating these inflammatory patients because, I mean, obviously it's a lot, I think, less emotionally challenging than, pediatric and adult cancer. But, it's really rewarding. Like you said about the story you asked me, just rewarding. I mean, people get awesome results
Feel
from
better.
it, right? And I mean, it's something where they've seen so many people usually and tried so many things and gotten so little relief, and then we can get them back to some semblance of normal.
Yeah, and it's covered by
insurance, exactly, which is great.
After they've dropped probably
really
so much
they've dropped
money
they've done PRP and all that. I mean that those are always tough treatments, right? Because for the people that work, it works really well, but for the people that doesn't work, it does nothing.
Exactly,
right, and that gets tough. That gets tough.
Cool.
I had a patient that was receiving low dose radiation in New York for lichen planus.
Yep, we do that as well. Yeah. We do that as well. Yeah.
Do like oral, or do you also do?
We can do electron therapy for that. Yeah.
The outcomes were really good.
Yeah.
Swallow, it was really hard.
Another one we do is hydritis suppurativa.
Yeah.
So if you guys see that, that's it. Yeah, that's one we can treat very well. Yeah.
Interesting.
Yeah, HS is, and that's covered too. Insurance covered. Yeah.
How quickly does that typically work? Is it against 6 treatments or?
It's 6 treatments, and it works much faster than the arthritis. It's usually within a couple of weeks that it tends to resolve.
And that's low dose too?
And another one what I do a lot of is Dupuytren's contracture.
Yeah.
Oh, yeah.
So I treat more Dupuytren's probably than any cancer site that I treat. I treat a ton of Dupuytren's.
Interesting.
Usually 2 or 3 a week because the hand surgeons have almost no options for those people. And it works really, really well.
What about
Carpal tunnel?
Carpal tunnel.
No, carpal tunnel. I wish I could help with that. Dupuytren's and Lederhosen, for the feet, works really, really well.
Interesting.
But carpal tunnel, unfortunately, because that's it's a structural issue.
That's cool. Okay. That's cool.
You can target. I guess you are targeting nerves. You could target the trigeminal nerve.
Yeah, we do. We do like I said, tennis elbow, golfer's elbow. De Quervain's. I've done several de Quervain tendinosynovitis. Those have all worked really well.
Paryani?
Yep. We do Paryani's. Yep.
There we go.
Not as common, obviously, but it's the same. That's the same pathophysiology as the the Dupuytren's.
Yeah.
It's that fibromatosis.
What does your dad think of all of this that you're doing?
My uncle, the radiation oncologist. Yeah. So yeah. That's right. Yeah. So my uncle, it's for him, it's common sense because they did all this stuff back in the 80s, right?
And they stopped.
And they just stopped. Yeah. So for him, it's like, of course you should be doing this, right? We should have never stopped, but we stopped because. Really, again, that public perception, but also the radiation equipment wasn't as good back then.
Yeah.
They used to do kids all the time for acne, and then they all ended up developing cancer, or many didn't develop cancer because we didn't have the ability to modulate the dose the way we can now.
And then also targeted.
Exactly. We couldn't target back then, right? It was totally a different ballgame. Heck, my grandfather was doing it before CTs existed. Think about it, they were using plain films to guide their radiation fields. I've seen some of them. It's crazy what they did. It's like a shotgun, but what could you do? You got a prostate cancer, you treat the entire freaking pelvis,
That's crazy.
Yeah.
Oh, that's cool. It'll be interesting to see what comes out over the next years.
I can tell you this low dose stuff's going to be everywhere. I started it in 22. Now I think Moffitt's doing it now. Yep. The folks in Clearwater are doing it. So everybody's starting to do it now. It's becoming.
But you were the first one here doing it.
First one in Florida. Yeah.
Good for you.
You plan on, do you want to be a part of the general use of it and help it get approved?
Yeah. Exactly. I want to see it grow. That's part of why I wanted to publish that research out of it.
Yeah.
Because, I think eventually the insurance may try to push back. But the more data we can come out of the U.S., the better.
More data.
When is it going to be published?
I don't know. I got a resident starting in September. So I'm going to have him put it together. Hopefully this year we can get it out.
Perfect.
That's the goal.
That's awesome.
Yeah. Because I'm not going to do it. So. Yeah, exactly. Yeah. I haven't published it as a resident.
pioneering all these new things.
It's exciting stuff. It's fun. It's fun. It's fun. I'm enjoying it. And
I totally approve of Jolie marrying Bodhi.
Yeah, right. It's going to happen. So it's going to happen. I mean, whether we like it or not.
That's awesome.